political culture was very different. Out of 60 councillors.
Well,
Good morning, everyone. This is the Health Scrutiny Committee meeting of the 3rd of December 2025. Welcome to all the members, welcome to the guests, welcome to members of the public. I'm Richard Howitt, the chair of the committee. Usual chair's announcements at the beginning. Feel free to take pictures and use social media during the meeting, but please turn your phones to silent or vibrate, and that encouragement is subject to not disrupting the meeting in any way. The meeting is being live streamed and a recording will be available to watch later, posted on the County Council's website. There is no fire alarm test scheduled for today, so if the alarm sounds, I will adjourn the meeting straight away and we'll leave through these side doors here and use the fire escape, which is next to the kitchen, just the other side of those doors in the corridor. The assembly point is the far end of the car park. As well as members from both our districts and the county today, I'd like to warmly welcome Jess Slater, the Chief Executive of Healthwatch, Cambridgeshire and Peterborough, who plays a really vital role in advising us as well as taking part in those meetings, and Healthwatch has a standing invitation to do so. I have one constitutional matter to put before you. Item 1 is notification of a change to committee membership, and Councillor Peter Fane was appointed to the committee on the 4th of November to succeed Councillor Anna Bradnam. It does mean that we won't have a vice chair today until the vice chair is appointed by the full council on the 16th of December, but a warm welcome to Peter. Great to see you here, and I've enjoyed our discussions already. Are there any apologies for absence and declaration? Sorry, apologies for absence, please.
Thank you, Chair. Apologies have been received from councillors Malinowski, Martin and Todd Jones.
And any substitutes that we know? No. Okay. Any other apologies anyone wants to record? No. In which case we then move to does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? No one's indicated, so there are none. We have the minutes of the 14th of our last meeting, which was on the 14th of October 2025. Are they agreed as an accurate record? Any objections at all on accuracy? Everyone happy that they're agreed? Okay, I will sign them herewith and pass them to Rashenda. And we therefore move into the actual scrutiny topics. Two big scrutiny topics today for the committee. Firstly, in a moment, we're going to be looking at the progress of provision of NHS dental services in Cambridgeshire. And then a little later, we're going to be looking at the revised plans for the Integrated Care Board covering Cambridgeshire and Peterborough, but going to be broadened across the region. Areas for us to scrutinise today. We're starting with NHS dental services in Cambridgeshire. We had a previous scrutiny session in March 2024, and today we're joined by Kate Vaughan, the Chief Officer for Partnerships and Integration at the Integrated Care Board, and Pam Green, Director of Neighbourhood Health and Partnerships for Cambridgeshire and Peterborough, and Jess Bender. Actually, is Pam here? Pam's not here, no. So it's just Jess. Welcome to Kate, but also welcome to Jess Benden, Primary Care Contracts Business Partner, Dental. That's a short job description. This is, it says here, this is Kate's first scrutiny session. Is that right?
I've done loads of other sessions, but I think it is my first
Oh,
scrutiny
right, okay.
here. Yeah.
Right. So you're
How
welcome.
exciting.
Kate is someone who works very closely with this authority and other partnerships. So hopefully you'll enjoy the scrutiny aspect of what we do in the County Council. I also want to place on record the committee's thanks to Simon Brignall for the evidence which he submitted on behalf of the local organisation known as Toothless in Huntingdon. Our thanks to one of our local dentists who gave their time to meet councillors Kane, Horgan and Garvey as part of our preparation for this session and to share their perspective on local dental provision. We do have a report in the pack, and I'll ask Kate and Jess to briefly introduce the briefly, I'm afraid, introduce the report because we want to focus on the questions.
Thank you very much. And I'm pleased you emphasised the briefly piece. I think the piece that would be great today is to have a...
And move the machine so that the microphone's much nearer your much better, yeah. Even closer, maybe.
What you want is louder, Kate.
Much better.
Yeah. So a bit more in terms of introduction. So I'm Kate Vaughan. I have in my portfolio across which Jan will talk to us about later, a broader geography than Cambridge and Peterborough, but the neighbourhood, place and partnership agenda. Primary care and dental care and optometry sit within that. But Pam Green, who was unable to make it today, is the director for this patch. Very passionate on this topic, and it's unfortunate she couldn't be with us today. But she is permanently in post from the 1st of October. So she was going to be your point of contact and is quite keen that I share her contact details as part of this as well. You've had a lot of information, I think, that's been shared in advance of this. So I think rather than going into too much detail on that, sometimes that amount of information is difficult to navigate. So I think the discussion today would be is going to be really valuable in terms of working our way through this. Jess is with me as a subject matter expert, and she has been within this part of the world navigating the complexities of it for, I'm not going to embarrass her, but for a long time. So if there's anything that's particularly technical or tricky, I think I'll bring Jess in if that's okay. So the points I just wanted to pull out in terms of starting the discussion is this is widely acknowledged that dentistry is a national priority, but also has national complexities. And it's an area that has been on a journey and will continue to be on a journey over the next couple of years. It's a nationally agreed contract, and it's for us locally to be able to collectively bring influence to bear in those conversations so that we can actually help to build our dentistry provision locally as well. We've got significant numbers of challenges that sit within this piece of the NHS recruitment and retention, which I think has been very live on this morning's media, is a key part of that. And what we've done, what the ICB has done in the last couple of years since we've taken over the management of the contract, is started to get under the skin of actually where our needs are, the demographics, but also what is in our gift to work with our local dentistry providers to understand how we work within the confines of the contract as it exists at the moment, but also looking at incentivising NHS work and that wraparound of the population for their dental care. We have done a pilot over the last couple of years. We can go into a bit more detail. You've had the details through, but it's worked with dental providers in the design of it, and it has been around creating flexibility within the contract. So payment and enhanced payment upfront to then allow that's quite all right. A different approach to some of the provision, looking at a wider multidisciplinary team approach to providing routine dental care, and also allowing us to have a little bit more flexibility in terms of how the funding can be moved around practices within year rather than waiting till the end of the year as part of a clawback process. We've used it as a test and learn site because it is a new concept, but we've worked with the national team on what that looks like and how we play that through. And at the moment, we are pulling together the outputs for the first tranche of that. We don't have the figures, unless Jess corrects me, but they weren't part of the briefing. But we are hopeful that the feedback today has been positive, and what we are heartened by is we can see nationally some of the findings and the headlines that are coming out around the need to prioritise prevention, knit our dentistry colleagues into the local neighbourhoods conversations, and also look at that broader multidisciplinary team, MDT, working within practices, impacting on which I think is the hot topic this morning, how we look at making a very viable and worthwhile career from a dentistry perspective, working with the NHS, which I think is one of our big challenges. I think, sorry, I'm just shutting my computer down. I think there is a conversation that's required around how we make sure that which is great to have Toothless in the room, and I'm aware of your work in different bits of the geography as well, how we work with our local population so they can understand some of the context within which their dental services are being provided, but also that they are fully empowered to access where we've been able to put additional capacity in around urgent dental treatments. We've had a significant uplift through this year, but the actual uptake of those appointments has been difficult to play through. So how we work with our population and our other providers, like our 111 provider, to make sure that those appointments are being accessed and people are able to access the care they need, but also as part of that process, be transitioned into routine dental care. I think we've got two pieces that have played through that, where we have had urgent dental appointments made available when patients have arrived. It hasn't been an urgent dental need within the strict contractual components or definition of that, and we've got some fantastic dentists in our patch, and we've worked with them on making sure that those individuals have still received the care they needed, but also then been transitioned into routine care as well. And I think the only other point that I would mention is the kind of broader recruitment piece, which has been in the media today. where we have got funding for 12 placements and have only to date been able to fill 4. We're working with dental practices to see how else we can utilise that scheme, but also how else we can make the career pathway from an NHS perspective as attractive as possible. Pam, who's not here today, has done a piece of work in Essex working with neighbourhoods and their local care homes and looking at how the provision of dental care within care homes and that kind of broader remit of the dental practitioners has helped with some of the recruitment and retention, but also it's helped to manage demand and also to ensure that people are able to access care homes are able to support their residents in a different way in terms of accessing care as well. Richard, I might leave it there if that's all right, and then we can take questions, unless Jess, you want to add anything?
That's great. Does Jess Slater want to add anything at this stage?
My questions are covered already by the councillors.
Right. So we're going to try to structure the questioning around the following headings: accountability, prevention, national policy, budget management, training, and then follow up to the motion that went through full council, any other issues that have come up in relation to our preparations. So we'll see how far we get through that in the time, but we try and structure the questioning around themes rather than scattergun, and we find that that does lead to a more constructive approach. On the first session, accountability, I'll open up on that one. It's a year and a half since there was previous scrutiny. Everyone at that time said the situation is chronic. And there was a feedback from our ICB colleagues: don't scrutinise us too quickly. Give us a chance, because it was passed to the ICB at that time. Give us a chance to get our feet under the table. Give us a chance to really address this before. So we've waited a year and a half. But I think it's fair to say on behalf of the Cambridgeshire public, there is still a perception that there is a chronic shortage, a chronic inability to access dental services. I don't think, as far as the public is concerned, that they've seen a material difference. And although you detail in the report the efforts that have taken place, and I don't detract from that or in any sense say that those are wrong, I wonder whether the level of ambition has been high enough. I wonder what's been said in the ICB about that. And I wonder if we shouldn't be saying that the level of ambition has to be higher in the period going ahead, because there doesn't seem to have been too much material difference. I also think we were told last time use 111, but I find that profoundly disappointing, really, that we can't do better on that. We can't do better than that. It is a backstop service, I know, but so I'm not saying that shouldn't be part of the toolbox. But the idea that that's the way people get a dental appointment seems to me that profoundly wrong, I have to say. So that's very much at the level of ambition, public perception, and let's say urgent arrangements to deal with the access problem. Councillor Horgan.
Thank you, Chair. I'd like to add that I'm very fortunate that I have a fantastic dentist, NHS, and we moved into the area 5 years ago and in the middle of COVID, and somehow managed to find availability to go on their books. So I'm sort of doing this from a position of sort of real satisfaction with my own dentistry service. But looking into this, and as our chair has alluded to, not everybody has that same experience. And my understanding was that there was an independent report that was done about 18 months ago, the IQVIA report, which explained chapter and verse as to what the problems were. So I'd be very interested to understand what action has been taken as a result of that. Has it prompted you to do more? Has it just made you want to fold up your tents and hide in a dark room? Or, what good has that report been to improve the services? Thank you, Chair.
Before I invite you to come back, is there any other member who wants to ask a question around the accountability of the ICB in relation to dental services? Please, Councillor Pitt.
Thank you, Chair. So the question I wanted to ask, I think probably is the right section. There's some encouraging numbers in terms of improvement that we've seen in the last, in the year that's referred to, but I don't have a sense from reading this report what the scale of the issue is. Like, do you have data on how many people don't currently, have regular appointments? And I'm sure that it's a complex scene and some people choose not to. I think there's a bit of there's a large grey area between people who want to and are unable to, and people who choose not to. Actually, I think there was a lot of people that sit in between that and would like to, and they find it a bit difficult and then give up. So I guess in terms of the total population, how many people are just not on dental registers?
Please.
So I do think it's a really fair challenge, and we do take it around level of ambition. I think the bit that I would like to just put the context around it, it is a nationally controlled contract. So what we are able to do with that is more limited than it is potentially perceived to be, which is why we did the piece of work. And I'm delighted that you're happy with it. I think it's really important as part of this scrutiny that we do recognise we've got some fantastic practitioners who are going over and above and doing an awful lot for their local population. But the IQVIA piece of work was to, and you're right in saying it gives chapter and verse. It gives the answer to your question actually around where we've got gaps and the areas where it takes, especially from a rural perspective, it takes the population a lot longer to get even just to get access to a local dentist, let alone then get on it from an appointment perspective. So that as a piece of work has given us our blueprint, almost for want of a better phrase, in terms of where our need is. And as you can see from the report, where we've had funding available, we've invested that as part in those areas which that report was flagging as being the most in need. So we've very much targeted, for example, where we've been successful with our 4 posts that we have recruited to, they have been in the areas that were targeted as most from a most need perspective, rather than going kind of out to all of the areas, which is the exercise that is now happening. The IQVIA, so in answer to your question around what has the work done, we're partway through the work, but it was quite a piece of work to land, because it wasn't within the national framework. It was something we were doing for our population in Cambridge and Peterborough, but working with 50% of our practices to create an incentivisation for them to do more activity. I might bring Jess in to give you a little bit more detail on that. But the way the contract works at the moment is the funding is allocated at the beginning of the year and not released until the end of the year, and the activity reporting and our ability to kind of scrutinise that activity is very much held within the individual practices during that time. So with the IQVIA work, working with practices, being able to incentivise them doing more than they're being asked to in their contract, so creating more access, but also allowing them to use that broader multidisciplinary team approach to those treatments, also just gave them a bit more freedom to wrap around their population in a different way as well. We're partway through that, but I'm encouraged. And in terms of your point around ambition, it's not something that is happening everywhere else. It's us having a detailed conversation, and you were part of that conversation initially, to understand what the need is, what the ask is for the population, and thinking what is in our gift that we can do, which is where we came to this as a piece of work. Jess, do you want to say anything more on the IQVIA piece? Do I switch mine? You're right.
Yes. Oh, sorry. Yes. Hello. So yes, with the IQVIA project, as with the detail that we shared with you, the piece of work that IQVIA did was to look through the financial ledgers of dentists that were willing to work with them and look at the population needs. So the first piece of work they did was built on the work that the dental public health consultant who works for NHS England and supports the public health team and the local authority, alongside our scrutiny team, really did a deep dive into the needs and the data that we have around access and so forth. And then IQVIA took that one step further to look through. And then looking at the very first report, they pulled out where we knew that there were dental access issues in Peterborough, Fenland, East Cambridgeshire, and then there are the areas that we really need to focus support, both with workforce and obviously access for patients. So what we have done and we found from this piece of work is that the reimbursement level of NHS payments to each contract is at 70%. So a model was devised to increase that incentivisation payment, as Kate has said, to bring the level of delivery to a certain playing field so that they can then recruit against the contract and help it to be more sustainable. So as Kate said, the data is being looked at. Currently, we're at the mid-year point, so all of that's being verified, and we can certainly bring data back to a further committee, but at the moment that's just being validated to ensure that we can see the trends that have happened since we started that project.
Okay. No, I'm happy to.
I just went to Councillor Pitt's question.
Okay, yeah.
So in regards to where we really understand needs, so because the contract, there is no registration, dentists don't have a list as such as you would with a GP practice. However, they keep their own recall list. So that's something that they maintain within their own businesses. So we really are reliant on need assessment data that the public health consultant undertakes, and any joint strategic needs assessments that are undertaken by the local authority alongside our business intelligence unit. So they look at hospital data and access. The difficulty we have with understanding the real need is that it's a mixed economy. So patients have a choice to go through the NHS privately or independent. And so because it isn't all NHS, we will never know the exact need, but we have an understanding of what we need to do. And we understand from piece of work we've done around urgent care that with the growth to do with the system, that we're looking around 14,000 additional patients probably need urgent dental care appointments, which is why putting the additionality in from the national initiative and then looking at the dental reforms going forward, they look to mandate urgent dental care, that we're trying to meet those population needs. So we really do rely heavily on the data that is shared with us through our public health consultant, and obviously working really closely with Healthwatch about local anecdotal information we receive from patients to see where we really need to support.
Not immediately, but if Sally Cartwright, our Director of Public Health, wants to contribute to a point later, please indicate and I'd be pleased to call you. Councillor Dupre.
Thank you. I just want to follow up that question on data because it really is important. The indication I have, and I've been looking through responses from quite a large number of residents to questions specifically on dental provision, is that it's been said that people have choice to go private, and some people have always chosen, or to go private because that's what they want. The vast majority of people, I think, who are going private in increasing numbers, going private not because they want to, but because that's the only way they can get dental treatment. And those who can't get NHS dental treatment are either going private, or they are going without, bluntly, or they are in extremis pulling their teeth out with pliers. And that's masking the real need, as is being said. There's also a situation in which there are people who are going to dentists quite some distance in order to retain an NHS dentist. I was talking to a resident in the north of East Cambridgeshire who is going to Bedford. And she doesn't want to go to Bedford. She would much rather be going to a dentist in where she lives or in her nearest major settlement. But she has no choice about that. It's drive to Bedford or not be able to access NHS dentistry. And if we're relying on secondary sources of data and seeing this muddled picture where people are behaving in ways they wouldn't normally behave because of the shortage, I wonder whether there are different ways in which we can derive more robust data that will enable us to assess that need. That's my first question. The second question on accountability, we're going to be talking later about the cost reductions and reconfigurations at the ICB. And in terms of accountability, I think dentistry has always been something of a Cinderella service within health. I do remember a long time ago, I think it was Theresa May, when she was Health Secretary in a previous government, saying proudly that she was reducing money going into dentistry in order to put it into frontline healthcare. And I'm thinking, well, what is dentistry if it's not frontline healthcare? But it's not ever really been perceived as such. And I wondered how much the necessary attention that the ICB is giving to reconfiguration and its own internal budget pressures from government is further taking its eye off the ball in the context of trying to oversee what has already been a very undervalued, by deliverers. I don't mean health deliverers, but I mean governments, undervalued part of the health economy.
The only thing I'd add to that, if we're addressing the sort of dividing line between public and private, we can do all sorts of things to try and push public, but private seems to be quite a lucrative incentivizer for dentists. And when I read in the report that part of the strategy is to not simply get more dentists, but more skilled dental assistants and hygienists and others, in my practice, to get half an hour with a hygienist costs £85. Right, there's very, very few people that can afford that, and so I don't criticize dentists, but it does seem to me that the pull of the big private sector fees is part of the problem here. And I think if we're going to help all these other dental related jobs to be developed in the hope of providing a better NHS provision, I wonder whether really that route is going to work. No pun intended. So, and I see Councillor Dr. Nawaz.
Right. Thank you. Yes. First, picking up on the points just being made by previous speaker, I believe Councillor Dupre, and picking up on a couple of points, I think it was Jess, was it, about the...
Do you mind just speaking into your microphone? Move the microphone.
I beg your pardon. Okay. Let me check a little bit. Bit of a logistics issue here. The dental, the intelligence unit and the data that has been collected, which they use to work with. Now, from my own experience, just to underline the previous speaker, when I was approached by a resident, the nearest NHS dentist we had from Whittlesea was in Hertfordshire. At the time, I remember it came to 57 miles from Whittlesea in Finland. So it would suggest that either your intelligence unit isn't working very intelligently or isn't very intelligent. We raised this issue at the last meeting. I remember vividly 3 or 4 of these issues, and I guess I would whether it should come under the accountability chair or perhaps under the training. I feel it could come under either. But as for the, looking at your report, the Lever 1 hasn't been enacted. And I fear that until and unless that is enacted, the other 3 or 4 levers are at best going to have a limited effect. Now, as to the choice between private or public, no, it is not a matter of choice. For some, it is. For the majority, it is a matter of compulsion, not choice. And it is either, as has been said, they try to scrape together enough money to get dental treatment, or they go without, which would perpetually aggravate dental health. And of course, dental health does impact on general health as well. So in the long run, where it may be felt that you are saving money. In the long run, you are actually having to spend a lot more if we take the NHS generally. Now, as for the disbursements to the dental practices, £20,000 being given to individual practices. This is given to whoever happens to run the practice. The dentists who are working there most often are the FIR or recently graduated dentists, and the disbursement is very often 60-40. The practice takes 60%, the dentist takes 40%, sometimes even less, sometimes maybe a bit more. And there is very little incentive for the individual dentist to entertain NHS patients. And I think that needs looking at, and also the data, I repeat myself, the data needs to be more accurately collected. And I think people like the people here who are in daily contact with the residents would probably give you a more realistic picture of the situation in their own neighborhoods. Thank you.
Thank you. And just to alert you, we've got a section on the national contract and national policy a bit later. So some of what was referred to there, I think is best answered under that. But I think it does apply in terms of your local discretion in the way that you're trying to use the monies that have been made available to you. Right, there was lots there.
Thank you. I think it's all stuff that we recognise and would agree with, and I think you're in a empowered position to talk openly about it. So that's useful, I think, to prompt the debate. I think your point around data, that was part of the reason why we did the piece of work to get under the skin of the data, just so we were really clear on some of the stories, as you've outlined, where there's the amount of distance people were having to travel to access care, and that then being the underpinning analysis that we then use to make any funding decisions. We have a fixed amount. It's not about cost savings. We have a fixed amount of allocation for dentistry, and what we've been trying to do is work on how we can create flexibility within our geography on how we use it, which is I won't necessarily go into it again, but that's what underpins the piece of work that we've done with IQVIA. And we circulated a presentation which gives some of the headlines you were looking for as well, around where we've got gaps and the numbers behind them, which the data then showed us. So I think we are in a much more informed position now when we have started the work about actually how do we create that flexibility. But it isn't a quick fix, and it is something that will play through as we are able to build the data to make the case, if that makes sense, that it is working. And I genuinely think it will be working. There is your link that you made, and we will cover it later, but from an ICB being reorganised at pace at the moment, and that national directive that's playing through there, I feel very passionately about this topic. Jan does as well, who's coming to speak to you later. So we've consciously made sure that we haven't compromised our dental capacity for leadership, and same with primary care, Optom, within that, so that we've kept a place-based team for each of our geographies to make sure that we can continue this work, and then also building this work into the broader, I'm sure you've all seen the coverage of it, the broader building of a neighbourhood offer. So there is that ownership of your constituent who's having to drive. Your 57 miles was the example you gave, wasn't it? And I think to Bedford for you, understanding how we can get that local ownership of that is a key part of that as well. So a headline bit of assurance, but hopefully that will play through as time goes on in terms of protecting that capacity at your local level. And I think if we're going to cover kind of the national contracty bits data, the other bits that I had to say were probably linked to them. Is that okay, Richard?
It is, thank you. Apologies to Councillor Fane, but I'm going to move us to the next section, but I'm calling you in that section anyway, so you can perhaps put together your contribution. In fact, I want to do that first. So we're now moving to the focus on prevention. and I invite Councillor Fane to address the meeting.
Thank you, Chair. I'm not sure that what I have to say is specific to prevention. I find it slightly difficult to divide the subject in that way. Unlike Dr. Nawaz, and I suspect others, I have to admit that I very rarely speak to my voters on the doorstep or elsewhere about dentistry. Although I am frequently challenged about cavities, I'm afraid those are in the roads rather than my teeth. And forgive me. But for what it's worth, I would say that I was lucky to have a good dentist who went, as all dentist practices have, and I focus my resources on paying for my children to have dentist treatment. I, as it happens, haven't seen a dentist for 10 years. I've been very lucky, but that is not untypical. And if you look at the DRIS scheme, it doesn't, of course, as currently, incentivise any dentists in South Cambridgeshire. I was also concerned to hear what Dr. Nawaz was saying about the way those funds are typically distributed. And it is a one-off scheme, as I understand it. I'm perhaps less concerned about training, more concerned about retention, and particularly of availability of dentistry services, if necessary, confined to health hygienism for children, because I believe we may be storing up a long-term problem for ourselves. And I share what Councillor Lorna Dupre expressed about, given the state of ICB funding, whether dentistry is realistically going to be supported. And I appreciate that we're mainly talking about a national scheme rather than one which ICB has control of. So given all those circumstances, I'm not hearing a lot that encourages me this morning to think that we will be able to tackle what may be a long-term crisis building up for the dental health of children and the long-term consequences of that.
Thank you. Councillor Garvey.
Do carers know how best to support those they care for to look after their teeth? Is this embedded in work with carers?
Thank you. And Councillor Dr. Nawaz.
Thank you. Yeah, this concerns, I guess, public health education. How have you or have you not disseminated the information about the significance and the importance of dental health from preventative point of view, and how far have the public been educated, I use that in inverted commas, to the linkage between dental health and the general systemic health? Thanks.
Thank you.
Sorry, I thought we would get another one. I might start backwards if that's okay, Richard. So the because they're linked as well, especially around children's, the preventative piece and the work that we're doing with the public health team, and you can see from your papers we've invested in that, just to underscore that unless we start from that point, to your point around children, we are storing up a significant rise in demand going forward. So how we work with schools, our health visitors, is absolutely key in terms of oral health, hygiene, prevention, but just those basic skills that will allow our future generations to be in a better position, or experience the same position that we were able to, as I can remember very clearly having those lessons when I was at school. It was very much part of the conversation. So making sure we don't lose that absolutely is a priority. And that's part of the work with Sally's team around understanding kind of how we not only do what we're doing now, but we look at what more we can do in that space as well. the broader the point around retention, I think was yours part of yours as well, and how you are creating, I suppose, the ability to offer an attractive career prospect and package for the clinical professionals that work within our dentistry. That also comes, I think, back to that broader approach to, I think, speaking to some of our dentists locally, the work they do in that space around prevention, going into schools, having those conversations is a really enhanced element to their role. And I think they are get quite a lot from that as being part of their broader career portfolio. So it's got the public health element to it, but I think it also has got a recruitment and retention element to it as well, because very often our dentists live within their communities, and it's also, they have vested interests, as we do, in terms of supporting the local population. And the more that we can build that, I think, looking to the future, and the more that we can create definition around that part of their role within our neighbourhood, I think is a key part of where we go from here. Your question on carers, I'm going to pass to Jess if she has any response. I think I've got opinions, but they're not going to. I think Jess will be closer to the detail.
So thank you. So we have a special care dentistry service who, as part of that contract, support the public health, oral health.
I do apologise for interrupting, but apparently there's some echo because Councillor Garvey, as you've left your microphone on. Do you mind switching it off? I do apologise. Okay, please carry on.
Cambridgeshire Community Services, part of their contract, special care dentistry, they do an element supporting the public health, oral health work that is undertaken in the local authority. And so as part of their work, they go out and do oral health promotion, and then they can work with specific groups. I'm not entirely sure if they work with carer groups, but I know they've done a lot of work with care homes and initiatives that we undertook when we were in NHS England, and then hope to re-establish back when we're back in the ICB. So I can certainly take that away and ask them as part of that portfolio if they can look. So if there's any particular groups that you have, I'll be more than happy to share that information with them.
Okay, that's very helpful. We're now moving to the section on national policy. Can I just say in introduction, obviously we don't expect you to speak for the government, but we'd like you to listen to the questions that the members want to bring forward. And obviously you do have meetings with governments, you hear what they're saying to you, and you are speaking to government, so you know what you're saying to them. So in the light of that, we ask you to comment on the questions from the members, fully appreciating that you don't speak for government. Let's just look who the first one is. Councillor Garvey again, please.
We understand that the dental contract hasn't changed significantly since 2006. Does the ICB believe it should be reformed? If so, how are they pressing for this?
We look forward to your answer. Councillor Dr. Nuez.
Thank you. I guess in a way I come back to the IQVIA generated lever 1. We were informed, we have some information, some anonymized and some not so anonymized, that contracts are being handed back to the ICB because, you know, the NHS contracts just are not economically or financially feasible. Bear in mind, I have said earlier that sort of 60% or more goes to the practice and 40% or less goes to the individual dentist. Now, you take into account the expenses that a dental practice would have, the dentists, the hygienists, the receptionists, the nurses, the X-ray machines, the equipment, the overheads. So no wonder that some of these contracts are being handed back. Now, is the ICB, or if you're aware, the government, looking into why these are being handed back and how the situation can be, should I say, retrieved, rescued? Thank you.
And I hope you could actually comment on the number of contracts that are being handed back, say, in the last year. I think that would inform my discussion. And for me, the government has said that it's delivering 700,000 extra dental appointments in its first year, and it set a target for Cambridgeshire and Peterborough of 14,195. And lo and behold, your report says that there are 14,000 extra appointments that have been delivered. And I don't want to suggest that there's anything less than full transparency and openness when you report that. But nevertheless, it's not very visible to the public. And when you put in the report that you don't want to identify where the extra appointments are because you want to make sure there's proper demand management, and I understand that. I don't think that's a bad argument at all. I respect it. But I do think there's an issue that we're being told nationally there are all these extra appointments, and people don't see or feel it locally. Which comes back to my original question about perception. But do you acknowledge that there's a need to be able to demonstrate that in order to win and keep public trust within the system? Those are the questions on national policy.
Thank you very much. And thank you for your preamble at the start around the parameters. So that's very helpful. So we haven't had any contracts handed back within our footprint. And I'd like to think part of that is because we are very openly trying to work with our dentists on how do we trial different ways of their, sorry, I realised I was wandering from my mic, different ways of them operating within the parameters of that contract. And that really has been done in conversation with them in terms of what would make it viable. To your point around overheads, each of these are individual businesses, and ensuring that there is a model and a contract that supports a model that makes it viable for them to do more NHS activity. That's our aligned incentive. So that's what's been underpinning with the data as the logic model for that in terms of some of the locations of where we've targeted activity. But that has been part of the conversation that has played through. It might not feel at pace because it's been a significant period of time, but actually the work is building momentum. The point around working with our national colleagues, it has been being at the front of those conversations to say, we are piloting a different way of doing this. Please, can that intelligence feed back into your national conversation? And they're very, very open to that. Another example, which is sitting with one of our Peterborough practices at the moment, we're also trialling the co-location of a dental practice within a GP surgery. And GP surgeries, as you know, hold a registered list and gives us a lot more ownership of that population and understanding of how collectively we are then working on keeping the access model in the right place, but also that kind of oversight and that wraparound that's required for the population. And we've started that as a piece of work as a pilot with the hope that, and we know there is interest to do this, working with other dental practices or where that alignment might work for them going forward as well, which equals a sharing of overhead costs, and it also equals a hub approach to provision of primary care. So again, the outputs of that will be going back into our national conversation because it lends itself to the broader conversation around primary care in the fuller sense as well. And that our national colleagues are very keen to be involved, to have that feed of data. So I think that we're all pulling in the same directions within the constraints that we are experiencing. But I think that from a Cambridgeshire perspective, I think we're at the front of those conversations, trying to push the envelope a little bit more, into, for want of a better phrase. What was the other pieces on the urgent dental activity target and that extra capacity? And there is other extra capacity other than just the urgent dental. Bringing dentists and practices to the table to take on the additionality of the appointments has been something that has taken a lot of conversation in order to make sure they're comfortable with offering the urgent dental appointments. And so the comms and the approach to comms has been part of that conversation. Our elected members have been brilliant in terms of promoting that this extra capacity exists, and the different routes for accessing it. And I think that will be a building picture as well. We're bringing on more providers after the first tranche to make sure that we are able to allocate all of these, all of the over 14,000. But then at the same time, also from that, not all of that, as I said earlier, not all of them are presenting with an urgent dental need. So there is also a knock-on in terms of additionality where those individuals are still being seen, but for a lesser need than an urgent one, but not being turned away, and then taking up a suite of treatment for that need. So that feels like a clumsy way of saying it, but it's more than just the urgent dental elements. So I think there is something, again, the usefulness of this conversation today, and also the brilliant work of Jess and her team, who field a lot of the inquiries and communicate the information back out. I think we're getting in a position where people are feeling more confident about communicating more openly about where that capacity is available, and that's part of the conversation that we'll take forward going forward. Have I missed anything? Jess, have I missed anything? Do you want to put your...
So there was a question around contract reform. So since 2022, the national team have been reforming the contract, obviously within the ICB and what is within our gift, as Kate has mentioned, we are implementing. In the summer of this year, there was a big consultation about the contract reform, and that looks at, or the consultation was looking at mandating urgent dental care within the contract, because at the moment, it is for the dental practice to clinically determine how they support patients and who they support, but having it mandated in there with the urgent dental care, that should really hopefully help patients who cannot access for urgent dental care at the moment. And another element that they brought in, because it is a contract of unit dental activity and not about patients seen, is to enhance the payment around band 2, the higher tier, which is for those really complex patients that have a huge number of cavities, fillings that require root canal treatment and so forth. So it's really helping those patients that haven't been able to access a dentist for those really high needs. And so they are offering a further additional incentivisation payment to the dental practices to ensure that the chair time that is being utilised for that patient is being appropriately used. And they were some of the bits, the really pertinent bits. There is a big piece around prevention that we'll work with the public health team and the local authority around, and trying to mirror the support that GP practices are given around their learning time, and giving the same to dentists too, to try and get some more parity. So they were the bits that they were consultating on. Sorry, I can't say it properly. We haven't yet heard the outcome of that consultation, but they are looking to rapidly implement those changes. And so, yeah, as soon as we hear, obviously it will be public news, but then they'll start implementing those from April. Any changes that are made will be made within our cost envelope, so we will be making sure that we're working with the dental practices to ensure that those that really need the help can access it.
I'm going to drive us on with apologies, because there are two other major blocks I want to get to, and we've got about 20 minutes till the end. So I'm going to move us on now to budget management, and I'm going to take Councillor Garvey next, but then it's Councillor Horgan. Could you choose one of your possible questions to prioritise in all of this? Councillor Garvey, please.
Is the ICB able to unilaterally change the funding levels for units of dental activity, or are the rates set nationally? Is the ICB speaking to the government and other ICBs about the urgent need to review these funding levels nationally?
And I think the important thing is that how far have you got discretion, and are you using it to the absolute maximum? It's implicit, I think, in what Councillor Garvey was saying. Councillor Horgan.
Thank you, Chair. Doing my research on this, I came across a fact which shocked me. And it goes back to the baseline year of 2004-05, where it was decided what the funding level for dental services in this country would be. And it says that only 50% of our population actually went to the dentist in that year. So therefore, going forward, dental services only need to be funded for 50%, that's half of our population. So that shocked me, to be quite honest. And obviously, since that time, the population's increased. So I appreciate that the unit of dental activity is the currency effectively here, but has it been factored in that the population's actually grown since that period, 2004-5, by millions of people effectively? Or are we still thinking that the population and therefore the number of unit dental activity is still the same of 20 years ago? Because I find that worrying if that's the case.
And for me, you've had an underspend. You've explained the reasons for the underspend. It hasn't been for the want of trying, and I completely acknowledge that. But the money's there. Could you have been using it in different ways in the meantime?
Thank you. So the rates are set nationally. And I think everything we discussed so far this morning about the pieces of work that we've been doing has been our way of being able to be flexible within those fixed parameters with permissions to understand actually how can we move the money around the system and around our providers with a bit more flexibility, as opposed to Richard's point as well. Earlier in the year, we've got a funding system that is fixed also in terms of when fund underspend is released and then how it is utilised and reallocated. So again, the IQVIA work has allowed us to be able to pull together a programme of work that helps us to be more flexible in that space. I'll let Jess say a little bit more on that if she would like to. And again, just linking back to the conversation we had, so the comments I made slightly earlier, as an ICB, that is what we've been feeding into the national conversation. We come from a brilliant system, and we've got a reasonable amount of profile that allows us a good seat at the table. And I think this work has also supported our profile and volume of voice, but I feel also this is why these conversations are so important, and having Toothless in the room and other groups and our Health Watch colleagues, I think there is a collective approach to also making sure that we're putting into the conversation the voice of our patients and articulating the need and continuing to do that, which we're committed to. But I think it helps also to have a collective approach to that in terms of the voice, our voices. Jess, do you want to add anything on terms of timing of underspend usage?
So in terms of our budget, it is set and it all sits within the contracts that we have across the system. So we have 73 high street dentist contracts, which I believe is what I said in the report. Sorry if I'm slightly wrong with my figures. So that it sits within all of their contracts. They have a specific amount of activity to deliver, and if they don't deliver it, we have a process called clawback. So they are given the funding throughout the year, and then we claw that funding back. So where we talk about underspend, we're actually talking about clawback. So we get that funding back the following year. What we are trying to do with providers where there is continual under-delivery due to workforce issues or constraints, or just not being able to deliver the amount that they have, we are trying to have those conversations at mid-year, which is where the aim is that they should deliver at least 30% of their contract by September. This gives an indication of whether or not they are on track to deliver activity and support to patients. So we're trying to have those conversations to resize contracts and reduce contracts where they can't be delivered. Once we've released that funding, we are then able to use that funding in a different way. We can then go out for new service provision, we can go out to areas of need, and we can offer this to providers that really can deliver more and have that retention of workforce.
To interrupt, I know you can do those things, but have you been doing those things?
Yes, we have been. Yes, so we have been doing them. So we were able to rebase some of the contracts last year or resize them. because we've been asked to follow some national initiatives, we have to find that within the dental allocation, and therefore we've had to prioritise funding the National Urgent Dental Care Scheme and obviously with the IQVIA project too. So we are reallocating the funding where we can. If we are able to reduce contracts in mid-year and they are not huge, if you like, a huge amount of activity, we are reallocating those out and offering those out to those practices already delivering. And as Kate has said, another project that we've been able to look at in the north, sorry, not in Cambridgeshire itself, so we will be looking at it more system-wide, is about that relocation of GP and dental, and that is reutilising the funds in a different way.
Thank you. The last substantive block, I might have a sort of any other business block, but the last substantive block is on training, and Councillor Dr. Nawaz wanted to address that.
Thank you. I recall vividly that in the March 24 meeting, I constructed and presented a very strong argument about the training provision. Having looked around within a radius of about 80 miles to the north, to the west, probably not so much to the west, but to the south and to the east, there was no provision for training dentists. And I think there was and there is a very strong argument to establish a dentistry school because I said it then and I say it again, we in the east of England, and I would say particularly in places such as Fenland, are the dentistry deserts. And what I have heard so far from you is that it gives me nothing to take back to Fenland. And Fenland has similar, if not worse, IMDs than Peterborough. And you quite rightly have shown some focus on Peterborough, but there's nothing for me in Fenland. Now, the wider argument I made was that if we have a locally based dentistry school, the statistics have shown that a lot of the people who train in that particular locality tend to remain in that locality. Not only that, but because we will have a lot more dentists to go around. And my proposal was that the Anglia-Ruskin University was probably the best base to establish that school in that campus. Now, Anglia-Ruskin already run a medical school in Chelmsford, so they have the resources and the know-how. And at the time, and I have to say at the time, I did have access in the right quarters, and I offered to help to kickstart the process. But since then, the only answer I have here, Integrated Care Board, a response. Now, I'm not holding you two ladies to account on this because I believe it was neither of you, if I remember correctly. Maybe it was the ICB itself, and maybe it could be asked again, Chair. The answer I have here is when I first looked at it, I thought, well, you know, ICB local national dental incentivization schemes. I thought, well, you know, so Humphreys in Yes Minister is going to be ever so pleased with this phraseology. But to me at first sight, it was just saying, oh, in layman's language, oh, what a load of bullshit. And I'm afraid that...
So I do have to apologise for that.
I take that back, Chair.
I do have to, yes, sorry to members of the public who heard that said erroneously. Thank you for taking it back.
Okay, but I think it gets the point across, the way that this committee is being treated in this context. I know you are very clever people, you're well paid, and I don't know about colleagues, but I don't get paid for attending here. Apart from a bit of mileage, I suppose, but we spend hours into reading, digesting, understanding these reports and researching into them. But an answer like this, a non-answer, is very discouraging. What is your response, please?
And just from the chair, both the note of the last scrutiny session and my personal memory is that everything Councillor Dr. Nawaz has said is true. And you're not answering individually. This is not about individuals. You're answering on behalf of the ICB. But it's fair to say there was a very clear commitment given 18 months ago to pursue some form of undergraduate dental training school in East Anglia. Nothing appears to have happened. The nearest to London and Birmingham. And as Councillor Dr. Nawaz correctly says, we all know that where people train, they quite often want to stay and practice. So it does seem the ICB has missed a trick there, having given a pretty clear commitment to us at this meeting. So I know that you weren't personally present there, but I think I want to just concur with everything Councillor Dr. Nawaz has said.
Thank you, and thanks for that clarification. I got slightly lost, unfortunately, with your question. Those conversations have continued, working with our colleagues in Suffolk, and I don't think we've got any further update other than that. So I'm happy to take that away and see where that has got to, because I agree with you. I think if that's something that we can achieve together, that would be fantastic. And I do know that those conversations were live, but I also know how difficult that is to land as well. So I think I'm happy to take that away and come back with a bit more of a detailed update. We can email that through as well.
Thank you. Okay. We've got about 5 minutes max. Is there any member who's not asked a question who would like to ask a question? I'm just going to see if any of those that have not contributed want to ask. Okay, I'm seeing one, which is Councillor Horgan.
Yeah, thank you, Chair. Not a new question. I wasn't sure that I heard or understood, if I did hear it, the answer to my point about the baseline 2004-5, population's grown at that time. Has the number of UDAs increased in proportion to the growth in the population over the last 20 years? Yes or no would be a good response, and by, is it keeping in line or what?
And I'm going to add, following up the resolution of Councillor Boulat to the full council in December 23, is access to dentistry more or less unequal compared with 18 months ago? And why do you answer that? And what are you doing to bring people with lived experience into the discussions about the future of dental health in the ways that we've been discussing this morning?
If I answer your first question, so this is a national contract that was brought in 2006. So the units of dental activity and the funding associated with each were set in the reference year of 2005. That funding has not changed. There's been an uplift, but as it's a national contract, we are given an allocation, and that is what we have to live within. So unfortunately, with growth in the system, I do not believe that we are matching the growth of the 50% population. So we are living within the means we have to ensure that we can provide access.
And then in answer to the second element, the lived experience, we work very closely with Jess and her team in order to make sure that we've got a feedback loop in terms of that lived experience, and that's us proactively working together, but then also reactively, because Jess's team have a regular dialogue with lots of our population around what is concerning them, and also in relation to dental, where they've got particular areas of concern that we can then respond to in terms of going back to them directly, but also feeding that into the broader conversations about what is working and what isn't working, and where we need to target some of our conversations. Jess mentioned earlier about a mid-year contract review and starting to have that regular dialogue with the providers. And that is also part of how we make sure that feedback is fed back into a service provision perspective as well.
And more or less unequal?
So we clearly have targeted additional appointments and provision in the areas where we have the data has led us to there being a greater need to address that variation and their gaps. But I don't have a neat set of figures for you, Richard. So I think that's something, unless Jess does, I think that's something we perhaps need to bring back.
We've had a long and extremely rich discussion. Thank you to Kate and to Jess in particular for being very candid in your answers and in a way that I found very constructive. And I thank you very sincerely for that. As always, I do a sort of quick summing up, which is absolutely imperfect. But then our Democratic Services Officer takes that together with her notes, and we form the recommendations following the meeting. I think we started by urging the ICB to be more ambitious. There still seems to be a gap certainly in terms of public perception, in terms of the level of ambition in this area. I think we heard the feedback about the Equivia scheme and the discretion that it may lead to in terms of increased payments. And I think we probably welcome that and want to encourage it. We did several members expressed serious concerns about the distance that patients have to travel to get access. And we heard commitments about getting data around that, and we'd support efforts to do that, as well as expressing our concern about the distance. The question about caregivers and work with caregivers, you made a commitment to come back to us with further information. We recognise that you are running a pilot, which is going to, you hope, and I think we'd support this, feed into national policy in the area, including in relation to changes to the contract. You mentioned the pilots you're also looking at in terms of co-location with GPs, and I think we would want to encourage and support that. We talked about the extra capacity for urgent dental appointments that's been brought in, but the lack of transparency around that, recognising some of the challenges, but urging there to be more visibility and therefore building of public trust in relation to that. We expressed some concern about the level of underspend and whether the money being clawed back was being utilised as efficiently and as productively as possible. We expressed concern about the failure to see concrete steps towards establishing an undergraduate training school in dentistry in East Anglia, and I think we would urge the ICB to continue those conversations, as you call them, but hopefully to reach some form of concrete outcome. And once again, as Councillor Dr. Nawaz said, the good services of this authority to assist in any of that are certainly available to you. And then you also made a commitment to come back on inequalities in terms of access and the actions that's been taken. So we look forward to receiving that. So having made those fairly quick conclusions, we of course hope those recommendations are helpful to you. That is the intention. They will be finalised and formally sent to you as well. And of course, we look forward to receiving the information in future that you've promised to send us during the course of the discussion. With that, that closes this section of the scrutiny, and we thank you very much for your participation.
Thank you very much for having us.
It's great that Jan Thomas has joined us. I'm going to announce a 3 or 4 minute comfort break for anyone who wants it, and then we'll start with Jan. Okay, I am going to open up. We're not caught until somebody comes back from the loo. Sorry, folks. I do apologise for this slight delay. It shouldn't last too much longer. I do apologise to everyone, not least our guests, for that delay, which was obviously unintentional. and it's the rules of the county council that it's the number of county councillors present that forms the quorum, even though we've got a well-attended committee. It's just what our rules say, and if I break the rules ever, then what happens is lightning and thunder comes down, and I disappear from this world. So we just do have to respect that. We're going to now do our second substantive piece of feedback in the morning, and we're going to look at the changes to the Integrated Care Board. We're very happy that Jan Thomas, the Chief Executive Officer of the Cambridgeshire and Peterborough ICB and future Chief Executive Officer of the Central East ICB, has joined us personally. Many of us know Jan well, and thank you for sharing your time with us on this important point. Kate Vaughan has obviously failed the parole board, and so you didn't get to escape from our clutches. I'm afraid you've come back for more punishment, and I'm glad you're smiling at that joke. When we deliberated whether to have this session, we are very aware that this is huge work in progress for the ICB, and that there aren't answers to lots of questions, because those are being addressed day in, day out in a process of change which is taking place. And so we understand that, and we don't have an expectation that there could be an answer to every question. On the other hand, we felt that the health scrutiny function in Cambridgeshire wanted to steer the process, make suggestions, hear what progress has and will be made, and to be able to comment on that, to try and be a constructive partner in giving some steering and suggestions in relation to the change processes going on. So it's in that spirit we've asked for this item to go on to our agenda. We'll follow exactly the same process as we did for the last report. We'll ask Jan and Kate to make any brief and please brief introductory comments based on the paper that you sent to us, and then we'll move into a series of bands of questions on different themes, which I'll announce as we reach each one. Jan and Kate, please.
Thank you very much. I'm not going to go...
Sorry, Jan, if you move the whole machine nearer to you, so
you're
speaking much more into the microphone, that would be great.
Is that better?
Much better.
I'd have went deeper as well. I don't know why. It's a strange phenomenon. Okay, so look, firstly, thank you very much. I'm very happy to come and talk about this morning. It is a very, very difficult time for all of the staff in the Integrated Care Board. So I do just want to say that straight away, because I know that we all like to talk about what we think should and couldn't happen, but there is a lot of people at the moment who have just been entered into a consultation about the size and shape, and with a significant reduction in workforce. So there is a big human factor in what we are just about to go through this morning. So this was not of our making. In many sense. So it was announced in early in the year that we had to effectively reduce the running costs of an ICB by 50%. We should remind ourselves that a large chunk of what we do is direct patient services, including the management of the continuing healthcare, things like the Section 117s for mental health patients, and also dealing with a high volume and cost in meds optimization. So people think about integrated care boards and they think it is about administration. It is a lot of clinicians doing a lot of work around making sure our most vulnerable patients are safe. But we were given the instruction that we had to reduce it. That makes smaller populations, when you're looking at the scale that we have to deliver. And at Cambridgeshire and Peterborough, we were on the smaller side of an ICB. That makes it unviable, and therefore, in order to make the £19 work, we effectively needed to work in collaboration with other integrated care boards. Looking at the geography and the benefits, we saw some real benefits in working together with partners, particularly when you think about the growth agenda that sits around things like the Oxford-Cambridge ARC, the growth that's coming in the middle of our patch. And also the opportunities for current NHS spend that goes down into the south of our patch into London. We saw some benefits in coming together across Hertfordshire, Bedfordshire, Milton Keynes and Cambridgeshire and Peterborough. So that is the geography that we are coming together as one. We have now a single chair of each one of the three. We are still three statutory organisations until the end of this financial year, where we will effectively become a new organisation as of the 1st of April, assuming we continue to get the approvals. I'll just stop there, and if there's any questions, we can then go straight into those.
Thank you. The themes I'll read out, so, which will help hopefully yourselves, but also members in terms of where you want to push questions. So we're going to start off with the reconfiguration and some sort of high-level, big picture questions around that. We've then got a section on data security that members, some members are very anxious to ask about. We'll then deal with the financial management issues. So hold on the finance issues until that section. And then we've got a section which is about follow-up to the scrutiny we've already done on the NHS 10-year plan, and being able to put some questions in relation to that with you. So hopefully that will give a guide to how we're going to try and organise this. On the reconfiguration, let's make explicit what's obvious, which is something that includes Luton, Bedfordshire, Hertfordshire, as well as Cambridgeshire and Peterborough, risks looking more remote. I don't discount what you've already said about synergies. Remember, I was a member of the European Parliament covering all of those areas, so I've personally been trying to ensure I was local across that wider patch, so I understand the challenges. But nevertheless, this is a Cambridgeshire scrutiny meeting. What are you going to say to the public in Cambridgeshire to give them confidence that decisions will still be right for Cambridgeshire, they'll still get access to the decision making, that it won't just be more remote from them and what their needs are? And a point I put to you, Jan, when we met privately not too long ago, I'm very worried that senior people like you, and lots of them, are going to be spending so long on restructuring and structural issues that some of the delivery issues will suffer as a consequence. And I put, if I was in your position, I would be worried about that. And what safeguards can you put into place, and are you trying to put into place that the delivery journey carries on, and that the structural issues don't squeeze out everything? And lastly, from me, what's the future relationship between the ICB and Cambridgeshire County Council? You know, we have partnerships in a number of ways. We jointly commission services in some ways. We spent a lot of time talking about systems and system thinking, and an integrated care system. And how are those principles going to be upheld in the new setup? So those are my questions. The next person is Councillor Dr. Nawaz.
Thank you. As I'm sure you're aware, the government have launched an initiative, Getting Britain Back to Work, essentially to get the, I think, 3.6 or 4 million economically inactive people with health-related issues back to work. And I think there's another committee dealing with that. My concern is that at the moment, the work-related health issues, such as the joint problems, rheumatology, orthopedics, mental diseases, there are huge waiting lists. Rheumatology, I believe, is 2 years. Urgent cases is 3 months. One wonders what is meant by urgent, or is it being redefined? Orthopedics, similar. Hand therapy is, I think, 12 months upwards. And mental health, the situation is that 25.8% of young people have mental health issues, and this rises as the age goes up. And the unfortunate statistic is that 53% of the people diagnosed with or who have mental health related issues never get to see a psychiatrist. And if I may also give another very sad statistic, is that the leading cause of death in the under 50s is suicide. Now, given this background, what I would like to ask you is, what extra resources are you making available in places, in particular, places such as Fenland and Peterborough? Both have similar IMDs, Fenland probably marginally worse, especially northwest and of Wisbech and Whittlesea area. What extra provisions or resources are you allocating in order to facilitate the government's initiative getting people back to work, in order that those people may see their GPs, not the ancillary staff and the specialists, in order to expedite their return to work? Thank you.
Thank you. And Councillor Horgan, please.
Thank you, Chair. My question will be a bit shorter. We've just had a scrutiny session on dental services and the challenges of managing the provision of those. My question is, what assurances can you give that the reduction in ICB running costs and staffing won't adversely affect the provision of dental services? Thank you.
And one I missed off the list, sorry. Healthwatch are here, obviously they speak for themselves, but what the government has said is that the functions of Healthwatch will be continued, but in different ways. Now, it seems to me, my reading of what the government has said is it gives some discretion to ICBs and local authorities on how to facilitate that. So what is the current thinking of the ICB about how the functions of Healthwatch will continue into the future?
Okay, so I'm going to address a number of them in the round, but if I haven't been specific enough, then do come back, and I'm sure you will challenge me on it. It is really important to understand that as it currently stands, the NHS has a huge demand and pressure on it that continues to grow and grow. As the commissioner of those services, I need to understand exactly what is driving that activity. It doesn't matter if it's in Cambridgeshire or Bedfordshire or Hertfordshire, each has the same problem in that we get long waiting lists because fundamentally a lot of people need a lot of services that we need to make sure are there. If I look at what are the biggest factors that will really impact how people use healthcare and the volumes that they use it, none of them are about us putting on additional services. Now, we need to do additional stuff to get through the volumes. But actually, if I want to look at preventing that, if I want to look at really how we do it, we need to go wider than just looking at what are the NHS services we are providing. And I start there because I can't keep on putting on more and more and more and more when actually we need to really help people with their metabolic disease, with their wider determinants, picking up the work well question and how do we keep people in work. We together across Cambridgeshire need to do a really good job of doing everything we can to keep people as well as possible. I will continue to work with our provider colleagues, with our patient groups, with colleagues in Healthwatch at a local Cambridgeshire level to make sure we are maximising every pound we get to make sure that is invested in the right services for patients. That is the absolute right thing to do. But I do want to be clear, we will never have enough money just to keep putting on more of everything. Therefore, it is how we work and how we work together that is most important. That is why the neighbourhood health agenda in the 10-year plan, in the discussions we've previously had, is absolutely critical to our delivery. And if we don't get the neighbourhood health model right, and I don't just mean the health model, I mean the whole model that keeps people as well as possible for as long as possible. Because the members of the public that I spoke to, and let's face it, we are also those people, they tell me that that's what they want. They want their quality of life to be as good as possible for as long as possible. So that should be our unifying aim. And therefore, in the new Integrated Care Board, we have heavily looked at how we want to work, and we have put a lot of emphasis and proposed resource. And I do need to be slightly mindful here. We are out to consultation for our structures. So this is all proposals because we are asking for feedback from our staff on this. So what we have proposed is that we have a dedicated teams headed up by Kate that will actually deal with how we get the delivery at neighbourhood levels to ensure that the care people get in their communities is joined up, not just between health and care, but between the voluntary sector, between our private sector, and all stakeholders that need to come together to make sure that we can keep people in their own homes for as well as possible. We have realigned the future proposed structures in order to meet that need. What we haven't done in the new structures is replicate what we already have. And that is a really important differentiation because we are being asked to do something different. The law hasn't changed. The Care Act hasn't changed. We are not losing any of our statutory accountabilities that we currently have. But I think us focusing on how we are getting that neighbourhood delivery right, how are we getting that into integration right, and how together across public health, care, health, together we can actually say we want to minimise people's use of healthcare services, not to deny them service at all, but to make sure it's available for those that need it most when they need it. And that is the focus area for us as an Integrated Care Board. I will be taking every decision through the lens of what best serves our population. The population that the new ICB is going to cover is 3.5 million people. We have a budget of 8.5 billion pounds. We have 293 GP practices. I mean, this is large scale. That offers us opportunity, but we have to be able to do two things. We have to be able to work systematically, use processes systematically to work at scale, and then we have to focus at a hyper-local level within neighbourhoods to make sure we are together working on the things that we need to do. We can't do that alone. If I look at the data across those 3.5 million people, I can tell you the things that will make the biggest impact are not about health. They are about, and I know Sally's and I've discussed this, Patrick is aware of this as well, but they are about how are we helping people stopping smoking? How are we supporting people drinking less alcohol? How are we dealing with obesity to help deal with diabetes? That is the real moonshot that we all have here, regardless of an ICB structure. The moonshot we have is metabolic disease, and I can do everything to reorganize what we're doing as an Integrated Care Board to make sure it's able to focus on those that most need our help, understand what is driving our risk, how are we going to help individuals lead better lives to mitigate that risk, and really do that in a way that is very targeted and that we have some priorities. So that does mean that there are things that we would have previously done that we are not going to be able to do. We don't know quite what that is yet because we have only just started the consultation. We've put together our new structures. And as I keep saying, the law hasn't changed. The Care Act hasn't changed. So in what we're doing, I have to put as much effort today, and rightly so, in critical areas like safeguarding, like people with complex needs, as I would have done before. We are working to make sure that in Kate's structure and also in the wider team that you have dedicated contact points available to you to make sure that you have people who are embedded and working in with Cambridgeshire. There is a lady called Pam Green who has already been appointed to lead that, and she will have a team of people working with her to cover those areas. So I can't provide assurance that it won't it won't be detrimental to provision. I can't do that right now, but what I can assure you is that we are absolutely focused on those most in need. We are really focused on reducing waiting lists. We need people to be productive as possible in our providers, and they are working so hard to do that. We need to support our staff at a time when this is incredibly difficult for them, because as I said, this isn't an administration function. What we do, it is a technical set of skills that we need to make sure that we can carry on doing and get better at. And to do that, we need to do all of that alongside our population. I was disappointed with the Healthwatch decision. Jess and I have talked about this, and we are fully supporting it. But actually, the work we're doing at Place through the likes of Kate and Pam, it is important that we don't say, and what are we doing about how do we engage our population? They have to be fundamental to standing next to us on the design, being there with us and doing it alongside us. Some of the skills that Healthwatch have got can no doubt add value to that, but we are looking at how we do that through everything that we do. Kate, is there anything specific on Workwell that you think would be helpful?
Thank you. There are a couple of pieces. I don't know if you're familiar with Workwell, but it's a piece of joint work that we've done, to your point, about getting people back into work, and also understanding that is much broader than just their health needs. So at the end of 24, we started a programme of work working with pretty much all the partners, with a huge presence from our voluntary sector colleagues as well, to build a programme of work where we were able to support. I think we're getting up towards 2,500 now since the scheme was since the scheme commenced, with sort of bespoke, tailored packages around how they are being supported to get back into work. And the feedback from that as a piece of work has been absolutely phenomenal. But the kind of overarching pieces, I think a lot of what you would have said makes up the programme is not typically health. And I think we used our ability to hold risk in that space to be able to front load that as a piece of work that, from a Cambridge and Peterborough perspective, we're able to champion for our population. We're almost a victim of our own success, really, because I think we've now raised the profile nationally of the piece of work, and we've had visits on an almost weekly basis, it feels, for different bits of the central government, but also kind of broader, to kind of try and understand how do we move the model into mainstream business as usual, which is the Get Britain Working is a kind of a follow-on and an adjunct to this as a piece of work, but all of it has supported having a different type of conversation with our population, which combines health, but also their broader needs for them as an individual. What do they need to thrive? And I think being able to pull teams together, and our voluntary sector colleagues are a massive part of this, where we have individuals who've got the time to focus and the continuity in the conversation, because they are clear assets within their neighbourhoods and their communities. It's been a bit of a game changer. And from a workforce perspective, as Jan's outlined, it is a difficult time at the moment, but I think schemes like Workwell have also enabled some of our professionals and our kind of wider support networks to be able to really see a difference, being driven by the work that they're undertaking in that space as well. We can give you more detail on that. It's been through the Health and Wellbeing Board on several occasions, and the Health and Wellbeing Board has been pretty instrumental in championing it as a piece of work along with us in the ICB. One other piece I just wanted to pick up from your commentary, one of your questions, Richard, is about the future relationships with the ICB and yourselves. I think it's really important to say, Jan has outlined it brilliantly, that we are moving into a different space, and in terms of more definition around our role as a strategic commissioner, but yourselves, you are also strategic commissioners, and how we work together is being built into the new governance model for the ICB. So we have a neighbourhood delivery committee, which Patrick, delegated from Stephen, will chair alongside Pam. So we start to have some of those combined conversations for our population in terms of make sure there's no delay in the decision making, but also that the decision making is being informed by all of the information in the round from all of our portfolios. And I think that's a really key change. And as somebody who's been pioneering for neighbourhood health and for a place-based approach for over 10 years, the context within which we are operating or going into an operating model for, with a level of clarity on what all of us are bringing to the table as part of that conversation, all of our individual levers, I think we have got an opportunity, a pretty unique one, to do a lot more than we've been able to previously, and to use one of your phrases from earlier, Richard, to go a bit further faster, and that ambition that you were challenging us on earlier being a collective one. And last, just from a mop-up perspective, the answer to your question around dental, it will be the same. So we have protected the capacity to support our dental contracts and to make sure we don't lose any of the pace that we're slowly building up in that space, as we talked at length this morning about. We need individuals like Jess, who was sitting next to me earlier, who've got that subject matter expert knowledge, but also have got the relationship with the practices to keep pushing that through. So that's been a key part of the conversations around the reconfiguration.
Thank you both. There's a lot there one can come back on, so, and I think we will later, but I also am aware there are other issues that members want to raise. So I'll move us on to the next section for the moment, but thank you for those answers. There's some specific issues that a couple of our members wanted to raise over data security. Councillor Garvey. Could you put your microphone on? I don't hear you.
We're talking about the next section, data security.
The data security section.
Yes, okay. There's concern from local residents and the local MP about the security of personal and medical data following the award of a contract to create a data platform for the NHS to Palantir. Palantir's expertise is surveillance software, and the British Medical Association has stated that it is not an appropriate partner. How confident is our ICB in the use of Palantir?
Thank you. And Councillor Dr. Nawaz.
Thank you. It follows on from the previous question. I did raise it at the last meeting, but there wasn't a very satisfactory answer. The medical information is becoming more and more personal, very intimately personal, and very sensitive nature, with particular reference to the use of genomics. The study of genes and their functions and the implications of those functions. The sensitivity is such that it has at least a potential to be weaponized. Now, we have seen about the G5 and G6 in the other technologies, and we were very sensitive, and countries such as China and Russia, we excluded them from our networks. Now, the genetic data and other medical information lend themselves to make the population vulnerable to population controls. It is already happening to some extent. And no, I haven't been reading too many science fiction books. These are facts. And it is a matter of national security, as well as what has just been pointed out, matter of ethics. It is an ethical concern, which I would also share, in that Palantir was instigated through the funding from CIA back in, I think, 2004 or 5 or thereabouts. And they proudly, their CEO has written on their website that they've been very successfully engaged in the Ukraine war, in the Middle East, and in other war theaters. That troubles me, because we are friends, yes, that, you know, whoever it is, when it comes to existential issues, friends can very quickly become foes, just as well as the other way around. So I have two concerns with sharing of this data. One is the ethical, which has been outlined, and mine is more of national security. And I suggested that perhaps we could engage with a British-based company to safeguard this very important data. And it has been said that there is a controversy about this company securing medical data and then selling it on, be it to the insurance companies or various other interested authorities. So and there are a number of ICBs who have chosen not to go with this particular company, Palantir. Would you have another look at that, please, for the reasons that I've just outlined? Thank you.
Thank you. I appreciate this is quite a specialist line of questioning that you might have anticipated, but it's fair to say a number of local organisations and individuals have been contacting councillors about this, and on a cross-party basis, there is some concern amongst the councillors. So to have you here and not have a chance to express it seemed to be a missed opportunity. I don't expect you to give us a broad answer on geopolitics. But ultimately, the question is what Councillor Dr. Nawaz said. Maybe you've taken a bad decision and we're asking you to think whether that should be reviewed.
Okay, thank you. So the Federated Data Platform is a nationally procured system. It is not procured locally by our Integrated Care Board. That's the first thing I want to say. I think people think it's been our decision. It was done by NHS England in close working with with colleagues. So it is a nationally procured system that went through a rigorous procurement process, and that is the accountability of NHS England. So that isn't our Integrated Care Board. So I'm not able to comment on what are the security issues with it, because that would have been covered in the procurement process with NHS England. I do want to make a wider point though, because we have to be really careful about not just with people's data, because I think that's an absolute given, but it is really important that we are able to support people to be as well as they can. We scare people, I think, too much about talking about what might happen to their health data. And the reason I say that is because it is really important that we are able to say to people, we can see that you have a risk coming and we want to help you manage it before you end up in a crisis with that. To do those kind of activities, we need to work with people, we need to have access to their data in order to be able to manage them well. Let me give you a really practical example. I know now that if you have a heart attack or stroke, your chances of having another one will be dependent on the treatment that you receive during and after that heart attack or stroke. That is a fundamental care pathway issue. Isn't it better that we can access your data and say there is an opportunity that you haven't been given as a member of the public to mitigate your risk of having another heart attack or stroke? And I know that because I can look at your data and understand that you have not been offered something as simple as a lipid that would help you potentially reduce that risk going forward. That is why access to data is so important. I think the public expect, if you've seen your GP and then you see a doctor in a hospital, that information is shared. I think people would expect us to be able to put services based on needs of the population. To do that, we need access to data. And I think we should change the conversation about data. I'm not in any way diverting away from the conversation that you will want to pick up nationally about Palantir. But I am absolutely imploring us to start having a different conversation about how access to information to help people live healthier and better lives is a good thing. It will support people. It will make their care much more personal. We live our lives now with our lives being personalised. You only have to say something somewhere and suddenly your feeds are all full of the one thing you had you looked at once. I had a look for something at the weekend. I can see nothing else now on my phone except adverts for this thing that I'm buying. Imagine if we had the power to start working with our population to say it is really important that you engage in the right activities to make sure you don't have another heart attack and stroke. We do that proactively. We work with people. To do that, we need to build public's confidence. We need to get them to work with us to make sure that we can use their data to help them. And I think the public would expect us to be using that to help them be as well as they can. While we still keep talking about sharing data being the problem, I would like to talk about how do we get the data in the public's hands? How do we get the patient records in their hands so it is their data that they can make choices about? And if they can make choice, then we can help them more. The more we help them, the healthier they'll be. And I think that's the debate that we should be publicly having, and we should be really quite clear on what's in it for people as much as what would be the risk against that.
Thank you. One follow-up, Councillor Dupre.
Yeah, I'm quite concerned about that as an approach. I mean, I think absolutely it is really good if you can get data in the hands of the public about their own health. And I really welcome the advances that have meant that I can get messages on my phone. I often see what's happening to me before my doctor does in terms of results from hospital tests and things like that. And all of that is great, but the risks are huge. And it is often said in terms of our personal data that if you're not the customer, you're the product. And I think there is a real danger of our data turning us into products being sold by companies like Palantir, the data that we have being used to promote all sorts of agendas without our knowledge or explicit consent. And Palantir, we have heard so much about, I believe, is a real force for evil in the world. But there's also a real risk for individuals about their personal data and gathering of their personal data for purposes that may then deny them healthcare and access to healthcare. The idea is, oh, well, you know, you've been profiled as the kind of person who will, that kind of thing. And I'm sorry, I see the wince. I know you're seeing this as a kind of a conspiracy theory, but I believe there's real dangers in the misuse of information to classify people into types that then says, right, okay, insurance is going to be a risk and other things are going to be a risk, and we are going to be treating you in some way differently because financially in the future you are more likely to be a liability than others. There is so much danger about this that while I accept the real potential for good in terms of public having their data, being able to understand how they can use that to manage their own health better. Nonetheless, we really mustn't be blind to those risks because they are very, very serious.
I think this is a specialist area.
Strike that balance is the question.
I think this is a specialist area, so this is the last contribution, and then we're going to move on. I would love to be asked the question once, can your information be shared for all time between any NHS employee, be it GP, hospital, or anybody else? Because you keep getting asked that question, and I always answer yes, because I basically agree with what you've said this morning, Jan. But there is a dividing line, which is that doesn't go for private sector providers who may use the information for other means, and there is a lack of public confidence in the safeguards that have been put in. Now, I hear the answer that some of those decisions are national, not local, but you are the person who we get to meet. You do meet government yourself. And so for us to express our concern about that is a legitimate role for our health scrutiny. We have dealt with this at length. Please give a brief answer if you want, or comment, having listened to what's been said.
So all I'll just say is the procurement process that went through has safeguards in it. I understand that there is a lot of narrative about it. It is not possible within the agreements, as I understand them, that any data can be used for anything other than UK health purposes. So can we just, I think we just need to be, I can speak to national colleagues and get some form of words back to you, but it is not as part of the agreement. I think it's really dangerous if we say that data is going to be used elsewhere and sold. That is not the agreement. That is not within what this company has been asked to do. And it is worth saying health is not the only government agency that Palantir work with. So, you know, if you want an issue about Palantir, you should think about, we just need to consider that. But I will come back with the formal words. That is not the agreement, really clear on that.
Okay, that's very helpful. Now, you've presaged already the financial challenges that you've got, and frankly, don't start today, do they? Have been there for some while. And so members now want to raise questions in relation to that. Councillor Horgan is first, please.
Yeah, thank you, Chair. Yeah, looking at the sort of earlier draft of brainstorming thoughts on questions, I'm going to change my question because you've already answered the two that I had. I think you've said this is going to be a big change for the ICB. So what I'd be interested in understanding, what do you see as the biggest risk? How will you mitigate against the worst impacts of that biggest risk?
Simplest questions are often the best. Councillor Fane.
Thank you, Chair. I have a feeling that I should be able to work out the answer to my questions from the papers, but I'll admit I've failed to do so. I'm trying to work out how does the budget for Central East ICB compare to the current budgets for the constituent ICBs prior to the required 50% cost reduction. So will Central East ICB funding then be spread equitably across its geographical footprint, or will some areas be given priority within the available funds?
And I note your answer earlier that you're out of consultation on some stuff, so you can't say too much about the conclusions after that consultation. I get that. But I think it's fair for us to ask you to, as you said before, you need to be honest about where some things can't continue. And when I heard you say that, I welcomed it, because I just think we need to treat the public as grown-up adults on this, and you can't do everything. And it's much better to be honest about that than it is to pretend that you can and then disappoint people because you can't in reality. So at that broad sweep level, to the degree you can answer it, where is there going to be less spending in the future than at present? Jan.
So I just want to differentiate between two budgets here. So there is the budget to run the ICBs and all of the services that we have. And we call that our running costs. And then we have the population allocation. The allocation is not, the way the allocation for the population is coming to us isn't changing. The way that we are funded to manage the allocation is. And that is what we've had the 50% reduction in. So I just want to be really clear on that, because I think sometimes we confuse those two things. So we've got to do the same. We're expected to hold the same statutory duties with half the staff to do it that we had before. So that's why working together at scale is the way forward, because there are some of those areas where you can benefit from functions being shared across areas. So let me give you a transactional example. It means we don't need 3 HR teams in the way we would have done before if we were 3 separate organisations. Now, our people workforce teams do an amazing job, but that's where we can look at the kind of efficiencies where we would have had one person managing a team. That person is now expected to manage 3. A team that is bigger, but it actually covers the 3 areas. So we are making productivity efficiencies in how we are running the organisation through working together. But doing this, I have always been and will continue to be an advocate for the ICBs changing. I don't like the way it was handled up front. I don't like the way that the ask became quite transactional, but what they are asking us to do is exactly the right thing, because we need to build an NHS that is thriving and sustainable. And the biggest risk that I think we face is if we can't work in a new modern way to be able to support our population to really mitigate their risks longer term, we will never be able to afford the volumes of stuff that we need. So let me give you a really practical example of how this kind of comes to life. In the NHS at the moment, we spend more on outpatients than we do in primary care. I'm sure each of you has had experience of outpatients where you think, well, actually, did I really go there and have something? Did my care fundamentally change on the back of why I went there? And actually, I met with somebody a few weeks ago who said to me, I broke my ankle, terrible ankle problem, went in as an emergency, had it, technical term here, fixed, and then was called back to outpatients. first time made complete sense. They'd had surgery, needed review. The second time, when they were up and walking around completely unaided, they worried about it. The third time, when they were back at the gym, they thought, actually, why am I going back to outpatients again? We have got what we've designed. We've designed that when we are worried about people, we add more in. We ask people to be seen again. What we need to do is work with the 10-year plan, use the technology, put the ownership back in the public's hands, make sure that they understand the opportunities to engage in their healthcare, because we've created the capacity for it to be there when we need it there, and not because we're doing things to people that are adding no value to them, and it is actually causing them to get up, to have to go to the hospital, maybe arrange carers and arrange transport, etc., to do something that is adding no value to them. So the biggest risk is if we don't take this opportunity to really change and focus on how we want to commission for those things that add the biggest value. I use outpatients as the example because most people have had the experience of when you go, you have excellent care from our clinicians. They do an amazing job. But actually, sometimes you think, did I actually, what's different on the back of it? Does anyone feel safer having had that? So we need to work out with colleagues, with the public, exactly what adds the most value and how we make sure we can provide more of that and less of the stuff that doesn't. So that is the kind of thing that we are going to be doing. So patient-initiated follow-ups, which says, actually, rather than you just being called back on a routine basis, here is how you can access this if you are worried. Here's how you can get back into services, will be much better for individuals, give them much more confidence, and actually take the burden off outpatients so we can see more new outpatient referrals, which means that people can be seen and the waiting list can come down. Over 80% of the waiting list is for outpatients. It's not for surgery. We talk a lot about people waiting for their hips and their knees, but actually there's a lot of people out there with medical conditions that are waiting to be seen that can't, because the volume's going into outpatients. It can't be right that we are spending more on outpatients than we are in primary care. That is so by working differently, by us able to target, by us being able to make different decisions, by us being bolder in how we commission services, still provide safety net for people, because I believe what the public wants is they want better access. They want better communication from the NHS on what's going on around them, and they want faster service. To do that, we're going to have to change some things and stop doing the things that aren't adding value and start doing the things that are. So I'm not sitting here now with a list, because those things that aren't adding value will go through everything, and they will be the marginal gains in each pathway to make sure that people are only getting what they need to. If I just give you another example. About a number of years ago, we did an initiative in the NHS to get cataract surgery down to 12 weeks. Years ago, I was working in an acute hospital at the time. We had to get that down. And so what we said was that actually you could be referred directly on from your optometrist. If you've got a cataract, you don't need to go to a first outpatient and you don't need a follow-up, but you will get a number to access. In the last few years, that has rewound so that not only do you go to your optometrist, but you then go to a first outpatient, you have your cataract surgery, and then you go back again. We've got what we've designed, and we need to make sure that the design of that is really focused on those really value added for people, and then we'll be able to shorten waiting lists, we'll be able to get people healthier. But to do that, we're going to need committees like this support on making sure that we're enabled to make that change and understand the risk profile that happens if we don't change. Because if we don't change and we've got waiting lists getting longer because we haven't been able to make those decisions, that is more risky for people's health than the alternative. Just on the spend equally, we have, as I said, the allocations are coming down into one pot. So we will be working through our planning rounds, which is now live, to make sure that we are clear on how we are purchasing services, where that is going for, and the consistency within it. We do take into account health inequalities. We do that across primary care. Some of the formulas we're already given have already got that inherently built into them. So it will become 3 pots into 1 pot. We won't then be going, oh, I know, let's move X to Y because we think that they've had it more difficult in the past. past. What we want to do is use evidence, use the health economics to say, actually, how do we want to improve that care for those for that population? And it might be about giving it locally, or it might be about supporting other services to help them live healthier lives. But we will be focusing on health inequalities. We won't be radically moving around money between areas at this early stage, because we need to work out exactly what we've got and how well it's working.
We're in the last block of questions now, so can I invite, and I understand Councillor Hogan has to leave, doesn't affect the quorum, but thanks to him. So can I just, I'm going to call Councillor Kane next, but other members, this is your last chance, so do feel free to contribute on any of the issues that you wish to, but Councillor Kane is going to start us off on the NHS 10-year plan.
Hi, good morning. I sit as one of the appointed governors on the Cambridge Peterborough Foundation Trust, and one of the things that was brought up in one of the last governor meetings was the lack of female inpatient mental health beds in Cambridgeshire, which was resulting in females being placed out of county, with obviously resulting in worse outcomes, you know, not being a great situation. I asked for an update at the last meeting, which I was told there would be something put in writing, but I just wondered if you had any comments on that situation and whether that is a temporary thing, or if that's something that is something that can improve. And obviously, given the change in the ICB, the mental health and the lack of those beds is something that really is of concern.
Again, that's a pretty specific question, but it reflects our democracy, that if members are hearing and seeing these things and they want to put them, so I'm sure you respect that. Other members, I think Councillor Dr. Nuez.
Yeah, thank you. Yeah, thanks. I actually really like this, the feel of this new 10-year plan, particularly these neighbourhood health services. Hopefully we'll have dentists, chemists and everything in there. My substantive question concerns health inequalities. These can be geographical, they can be along the ethnic groupings, or gender-based. I couldn't see anything in this, in the report, about the health strategy, men's health strategy in England, which has, I know, featured in the national plan. To be more specific, I mean, I'm sure you're aware of that the testicular cancer deaths, leading cause or one of the leading causes of death is the testicular cancer in the younger 15 to 45-year-olds, and then the prostate cancer. And another leading cause, if not the leading cause for young men under the age of 50 is suicide. I couldn't see much mention of that. Could you possibly have another look and maybe incorporate and even prioritize these health issues for men, please? Thank you.
Councillor Pitt, please.
Thank you. So it's probably more of a general comment. So I really appreciate all of the discussion so far, but I think, I mean, notwithstanding, I don't have a deep understanding of data security, but I really welcome your pushback about the benefits. And I think, you know, in terms of the 10-year plan, you know, you're speaking really eloquently and passionately about what we can get from the move to digital. So I'll just, because there's been quite a lot of pushback on that, I really want to say that I really welcome that response. And also in your first speech, just talking about the move to prevention, I absolutely agree. And again, it's really great to hear that that's the first thing you brought to this committee. I just wanted to share also, so at Huntingdon District Council, we have a programme called the Community Health and Wellbeing Fund, and I could see nodding heads there. So that kind of work, I guess the point I want to make in terms of the cut in budget, I think there's a lot of opportunity to be quite innovative in the way that we do prevention. I mean, you mentioned about, you know, reducing people, encouraging them to stop smoking and drink less, absolutely. But I think it goes even more upstream to that, to how do we create those community connections that help people support each other. And that's the beginning of that journey to a healthy lifestyle. And I think NHS doesn't probably have historic experience in that. I don't think councils necessarily do as well. But as a, you know, the voluntary sector is probably closest to it, but it moves in its own way. So how can we bring all of those different strands together to get the highest upstream impact in prevention?
Thank you. And just say whoever's operating the video, that was Councillor Pitt from Huntingdonshire District Council, not the name that was displayed on the screen. Jess, did you want to? You don't have to, but if you wanted to add something, this is the moment.
Yeah, there is something I want to add because it was mentioned in this paper because we talked last time to Louis about accountability for withdrawing services from community and from voluntary sector, in particular the Arthur Rank Hospice decision. And when Pam Green came to South Place, we talked about accountability there and how the partnership holds each other to account. So I didn't know if there will be any mechanisms going forward with the partnership about holding organisations, independent NHS providers, to account on decisions around community services and whether they could be challenged at any time, because although the public have challenged, Health Watch has challenged, it didn't actually make any difference. And I was wondering with the new structure, is there any movement in that around providers holding each other to account?
Thanks. I do have one more question myself, but I'll pause and allow or invite you to respond to those questions that you've heard.
Yeah, so when I look at the priorities for the coming 3 years, we have just published our commissioning intentions. The first priority within our commissioning intentions is mental health. We are unashamedly putting that as the first priority in what we are doing. The other ones include cardiovascular disease, which links to what I've talked about, respiratory disease, which I've talked about, and what happens in advanced illness, and what do we how do we best address cancer. So in the question about mental health and specifically on the beds, I think we have to work really hard to make sure that we have a sustainable model for mental health going forwards. We talk a lot, and rightly so, about the waiting list that we have for things like ADHD. We have long waiting lists for these services. We talk very little about acute inpatient beds, and that isn't okay, because these are our most vulnerable and most challenged individuals. So we need to work out how to get a balance on what we are doing, to be able to say, it's not that we're not saying the ADHD isn't important, but there is a lot of volume there for things that are going to have an impact on people's lives, but not have the material impact that serious mental illness does have. So we are going to have to continually balance those two things off going forward, but we are starting that with mental health being one of the review areas, and how we create a sustainable model. It comes also to the men's health strategy that's just been released by the government. I think it was released a couple of weeks ago. What it's actually asking to do is exactly aligned to what I've been talking to all through this, which is how do you take more ownership about being as healthy and as happy as possible through your lives. It also then links to screening, and one of the things that isn't just a prevention, but is actually really important, that we maximize how many people are accessing screening. To do that, we need access to their data. We need to know if they have accessed it or not, what are their opportunities, and how do we really make sure that we engage people, we activate them in wanting to actively participate in screening. So we're just digesting what's in the men's health strategy, but it's the themes there are the same thing. How do we empower people to take control of their own health? How do we collectively work together across multiple agencies? The NHS can't solve this. This is on everybody, and it might be worth if Sally can come in and give us some comments on the prevention, because public health are accountable for how you do that longer term primary prevention, but how we draw that in and make that as part of a seamless pathway for individuals within their care. And Kate, before we go to Sally, I don't know whether you want to make any comment on the Huntingdon.
No, just that I love that it got a name check. It's a really important piece of work. The point that I wanted to make, which links again, maybe it's a segue into to Sally, is we have had guidance from the Department of Health and Social Care, which is very clear that actually health and our councils are being mandated, although we're doing it already, to work together to pull together plans at neighbourhood levels, map the capacity that we've got that sits around our population within those geographical footprints, and working with the Health and Wellbeing Board to oversee actually how we agree those plans to support the local populations, but also then are they having an impact, keeping that in a very operational space to understand actually where we've got gaps in capacity, but also where the prevention activity is having an impact, and actually where we are as a consequence being able to see what then that means for outcomes for our population as well. So it is very much a combined effort, and I think it gives additional definition to the role of our Health and Wellbeing Board, which I think we've collectively done a lot of work on, which has been to the workshops, etc. as well, to pull into a space where actually it's less about commentary and more about action and activity and how it is responsible for the outcomes of our population. So I think it's a really positive step forward. But that join up of we've got separate place teams at the moment between our two organisations from a county council perspective and a health perspective, which doesn't really make sense. They've got different priorities, but combined they have a lot of overlap. So how we're looking at that limited resource also to wrap around the population is as important as the join up in the broader conversations around health and care in the kind of traditional social care and health provision perspective as well. What we can do to support the building of our community assets at a neighbourhood level feeds into the conversation around suicide, around men's health, around just that family wraparound. Sally, do you want to add anything to that?
Thank you. I guess the main point is that it is very much a partnership. So from a public health perspective, we commission and undertake a lot of work around prevention, but that's not in isolation. So it will be very much in partnership with ICB colleagues. So an example of that is that we are just about to mobilise our new, we call it behaviour change service, but the service that delivers stop smoking, weight management and all of those services. And that really needs to be linking into the neighbourhood agenda. So it's very much a place-based commissioning model, and the pathways need to connect across all that we've been talking about. So where there's people that smoke in hospital, are they referred into the stop smoking service? Pregnant women who smoke being referred into stop smoking service with bespoke services for them. So it all needs to be connected and is being connected, but that's where that partnership is really important, and the opportunity of the neighbourhood work is really key to that.
So last question for myself, and it was going to be on the localisation agenda. I love that last answer from Kate, by the way. And there should be one team in my view. I'm not in the majority group of this council anymore, so that's up to others, but I would strongly support what you said. But to Jan, you know, we've been travelling this journey together, haven't we? I think in the Health and Wellbeing Board committee, in common with ICP in the past, we both know it wasn't perfect, but we made a damn good try of it, I think. A really good try at doing that. And each time we tried to improve, and I think we were getting there. And it was motivated by putting the needs of the people we jointly represent first. I'm worried that we'll lose some of that in the new setup. And I wonder if you share any of those worries, and if you can think of ways that we can try to ensure that doesn't happen. As I understand it, the government is not very happy with ICPs and wants to put more power into the health and wellbeing boards and to their strategies. But a problem with that is we know there was a chasm between really good work going on in the Health and Wellbeing Board and decisions taking place in the ICB, Cambridgeshire and Peterborough that were quite a long way distant from that, and vice versa. Right? Please do disagree, that's fine. But that was my perception and my former vice chair. And I'm worried that the gap between the two is going to grow larger rather than smaller. And then on the issue of the local infrastructure that you've talked about and Kate was just talking about, there's a big difference between a local infrastructure that provides space for talking and a local infrastructure that genuinely influences decisions. And I'll give you an example, which is not the health service, but which is this council. We have a whole communities function. We have brilliant community workers out there. But how much do they do brilliant community work, full stop? And how much is it really linked into the decision making of this council and making it more responsive? And I would be critical of our own council in relation, constructively, but constructively of our own council in relation to that. So this isn't about lack of trust in the ICB or our health colleagues. It's a challenge. It's a challenge to make these things genuinely the heart of decision making. And I think it is fair to say that a structural problem with the old ICB was that the hospital-based health trusts had the greatest small p political power within it. So it was a sort of structural problem that made transferring from acute to community more difficult, not deliberately, not because those people are bad people or anything like that, but because they're the power brokers in the system, and we never really changed that. There was a lot of talk about it, but we never really changed it. And of course, what happened is you commissioned consultants to try to map out the next stage of integrated neighbourhoods. But their recommendations only came when this new set of structural changes were brought in. And I wonder how far those recommendations will still be enacted and how much you're having to tear them up and start again. So I suppose my question is, what is it that needs to happen to make sure the health and wellbeing boards truly have the powers in the system that the government says that they want? And what can you and we do to make sure that whatever locality structures we bring up genuinely impact services, not just give the impression of being a point of access and no more? Thanks.
So I'm going to talk about something that happened at Health and Wellbeing Board. Just to be clear, we are absolutely committed to keep working in that joint way between what was an ICP and Health and Wellbeing Board, how we co-lead things and how we need to work together. That is, there's no question about that, because if we don't do that, we won't be able to achieve our ambitions. So there is absolutely no question about that. And again, we've not only built our it's not only our intention, but we've built our processes and our proposed structures around that as well. So that's how we are building for the future. The issue you raise about the translation between policy and delivery, I think, is the absolutely critical one. Because we can write the best documents in the world, but if we then don't actually spend more time about the delivery than we do on the policy, then we're going to kind of keep doing a lot of what has happened in the past, which I would agree with you about there being quite a lot of talking about things. So I just want to talk about the strategy for obesity. So we had a meeting 8 weeks ago now, where actually the place-based were asked to bring their information about obesity. What they brought was the services that are provided on obesity. The services are not going to get us out of the obesity problem. A unified approach to how we're tackling obesity, everything from school meals to provision of fast food, to what's provided in our supermarkets, and then complemented when people need it with what might be a right end point for a very small number of people, a medical intervention, if is needed, is the debate we need about obesity. And I know that the Health and Wellbeing Board stroke ICP now is committed to actually making obesity at the heart of what we do. But that isn't just about public health and NHS. That is about a commitment from all partners to say, if we want to tackle obesity, we've got to do it in a really strategic way, but we've got to focus on the delivery and how we are doing that differently, and it has to be joined up. So it's my hope, Richard, that we don't just come out with looking at what's the next neighbourhood model, what's this and what's that. But if we are committed, can we bring all of our assets to the table to deal with all of those issues, to make sure that issues like obesity, which is fundamental to all of our sustainabilities, not only personal sustainability, but actually we will use more services across health and care unless we can actually deal with those issues around metabolic disease. So I use that as the last example, Richard, because we've talked a lot about obesity and we talk a lot about the small services that affect the absolute minority. The conversation that we need to be having together is we need to really shift the dial. Obesity is one of the biggest things that we need to go for. I am not convinced that together through the Health and Wellbeing Board that we are really committed to bringing all of the assets to that. So as an ICB, I will do my best to keep showing up. We will show up. We will keep contributing. We'll keep a hand on the NHS. My ask back to you is how do we make sure that you are bringing all of the assets to make sure that this is a real team effort and that we can do it together, because without fixing things like school meals and what we are doing there, and I know it's a really wicked issue, we're not really going to hit the childhood obesity problem. That's what came out of that health and wellbeing really good interactive session, and that's the stuff that we need to make sure we're taking forward. So let's not make it binary about health and care. Let's make it about the grey in the middle, which is the thing that really accelerates us forward.
That brings us to the end of this section of the questioning. Just checking the time, no other hands. In which case, I'd like to really thank Kate and Jan. It's a pleasure to engage in the debate at that level. We very much respect the work that you're doing. We hope once again the recommendations that we bring forward will help nudge you in a direction probably you want to go in any case, and certainly help in identify priorities. As ever, I will give a quick one-off summary of some of the main points that we've heard. We've heard from Jan that she very much wants to continue the local partnership approach and agrees that the prevention agenda is the shift that we want and need to see. We did express concern that structural issues and changes are in danger crowding out some of the service improvements that we all want to see, and to sort of ask our ICB colleagues to guard against us, against that rather. We did hear a reminder that the statutory accountability of the ICB under the Health and Care Act is unchanged, and I think we'd want to reinforce that, including our own role in relation to that. We heard a description of the new team that's being set up that will enable interaction with Cambridgeshire within the Central East ICB with dedicated contact points. I think we'd want to welcome that and want to enthusiastically engage with that and try and make it work. I think we heard that the ICB will have to focus on where there is most need. I think we hear that, and I think what we hope is heard in reply is that we and the public want transparency where you're not doing things. We want honesty and transparency where you're not doing things, even though that then sometimes leads to difficult conversations. But it's the other side of the same coin if we're going to make a success of all that. On Health Watch, I think we heard a commitment to engagement with people, copying the best of Health Watch. I hear that. I didn't really hear an answer about the functions of Health Watch being maintained. Like, you came up with a new health strategy, didn't you, about 2 years ago, with the most brilliant public consultation, and Health Watch was already there and part of it. So I think this isn't just about good public engagement and consultation. It is about recognising that Health Watch provides an independent check within the system. And I invite the ICB to continue to reflect, including with this council, about how that independent check can be maintained within the future. We had a big discussion about data privacy. I think we do note, and some councillors wanted to very much welcome the comments that were made in reply about the advantages of digitisation of health services and being able to target in that. So I think those points have been heard and welcomed. But I hope that some concerns about data privacy are there on the table among some members, and you've kindly agreed to talk with national colleagues to come back with some further information to try and reassure us on that front. You've talked about patient-initiated follow-up. the broken ankle example, and I think we'd want to welcome and encourage and support that type of movement. In response to questions from two members about mental health, you've said that mental health is the first priority in the new draft commissioning plan. I think we want to welcome and endorse that. I think we'd also want to welcome the commitment that you've given to continue joint working with our Health and Wellbeing Board and to encourage that, but also to hear what you've said about all partners bringing all assets to the table. I think that's a challenge to all of us. It's a completely proper challenge for you to throw back in our direction as well, that we should welcome, and it's a test probably for all of us in making that approach work. I'm sure I've missed out some important things there, but that's why Rashenda is also taking notes like mad. The process that we use is that she takes the summary that I've given with her notes, and then we come up with formal recommendations from the committee that we will then formally send to you. It's been an extraordinarily rich session. I don't know whether a year's time is too soon, but is a year's time might be a good time to invite you back? Yes, I'm seeing a nod, so that's really nice. You know, I do think we're very pleased that our Cambridge and Peterborough CEO is going to be the CEO of the new setup. We've got an established relationship with you, and we want to thank you, Kate, and all your colleagues, of course, for your commitment in working with us. That closes this item. Members stay. We've got a little bit more business, but to Jan and Kate, thank you very much. Right. Health Scrutiny Work Plan, pages 35 to 38. My thought is we won't take any decisions today. I want to sit down with the new Vice Chair when appointed, and we'll go through with officers all of the different suggestions that are there. But does anyone want to comment or add to the items that you see there on pages 35 to 38? Jess, please.
I will send these through to Rashenda, but there's growing concern around non-emergency transport across the whole of the county, and there's been some, I know there's been some media coverage around it, but we've been gaining information over the last year around non-emergency transport that is commissioned by the ICB. I think it does deserve a session.
Very helpful, thank you. Any other members want to add to any comments or suggestions in relation to the work programme? Councillor Dr. Noaz.
Can we come back, revisit this future work, maybe at the pre-meet? I did have a few items, but I'm not quite ready yet.
The answer is yes, and I just say to all members, you're welcome to contact through Rashenda is helpful because then it can go to all the people that need to see it. But you're welcome to suggest items at any time. In the pre-meets that we have, we'll definitely allocate a bit of time there to that. But because of the change in Vice Chair, I've just halted any decision making about this because I think it's the Chair and Vice Chair should come to recommendations about this. So, but we'll do that very soon after the 16th of December, I hope. But feel free to suggest things at any time, and definitely I will allocate time in the pre-meeting. And just for members of the public that are watching at this point, the pre-meeting enables us to discuss in private the scrutiny, to come up with lines of questioning and order it so that we get the most out of the questioning period. There are no secret decisions taken in those meetings. It's very much about us preparing to make sure that the quality of our questioning is as high as possible. So just to reassure the public on that. So having said that, could we just note the health scrutiny work plan? Seeing nods, anyone disagree? Yes, that's fine. Recommendations tracker. Do you want to say anything introduction of that, Rashenda? Pages 39 to 50.
No, Chair, I think it's fairly self-explanatory. We will continue to follow up on any recommendations where we haven't had responses. Obviously, some of the things from today's discussion will reflect in there, but yeah, happy to take any comments.
It's quite a long list, but it's the way that we check what we've recommended actually happens. So it's a great function. Anyone want to raise any of the items in the tracker? No, so that's noted with thanks to members. In which case, thank you as ever to Rashenda, to Patrick and Sally as well for being with us throughout. I would just want to say from chair, I think our preparations meeting this time really worked. I felt that we had a really good structure to the questions that we put. And I felt we were really effective in that questioning. So well done, everyone. And thank you very, very much for your contribution to all members. Having said that, the meeting is, our next meeting is 24th of March. And I now declare this meeting closed.